Hello, pharmacists and friends. Today is March 14th, 2023, and welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen to find out how pharmacists and pharmacy students like me can improve population health, health equity, and patient care through advocacy and education. My name is Jake Lawrence, and I'm in my sixth and final year of pharmacy school at the University of Rhode Island, working with the Rhode Island Department of Health alongside my professor, Dr. Bratberg.
And I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the URI College of Pharmacy and the academic collaborations officer at the Rhode Island Department of Health. So we got a messy weather day today, just like every single time we record the Regimen.
I know, New England is not on our side. I don't think we've had one recording where it's been bright and sunshiny, or at least just cold.
Yeah, and our special guest needs to get on the road before it's covered in wet snow. So we want to make sure we
hope she's able to make it home.
Yes. So we're going to pack the listener with all kinds of fascinating facts about RSV vaccines. Of course, last week we had our podcast on prison health, and appreciate your listen. If you haven't listened yet, tune it up. It's right there. But we were going to talk about emerging vaccines. There's a Lyme vaccine, which is especially important to those of us in New England. There's a norovirus vaccine for all those GI illnesses, but I think we're going to skip over those vaccines because there's a lot more exciting and emerging data on RSV.
Yeah, so hopefully the work that's being done on those vaccines, we can see, maybe be adapted and applied some new methods to see some greater success like we're seeing with these new emerging RSV vaccines. There's still a lot of exciting things going on, specifically with pediatrics and geriatrics. So we have the perfect guest on today to talk with us about the ped side of things. We have URI professor and pediatric pharmacy specialist, Dr. Kelly Matson. So Kelly, would you mind introducing yourself for us?
Sure, thanks, Jake. Ultimately, as you said, I'm Dr. Kelly Matson. I work at URI as a clinical professor in pharmacy practice. I have a clinical site at UMass Memorial Health where I work as a clinical pediatric specialist.
Awesome. Thank you so much for joining us today. We're so happy to have you. This is going to be a great conversation. And again, you're the perfect person to speak on this. You work and see this every day. You teach about this to us students and again, your residents at your clinical site. Could you share your experience working in these different institutions and kind of the examples and prevalence of RSV you're seeing in your pediatric patients?
Sure. Before I start, I just want to say again that my opinions that I express today for this podcast are my own, so not a reflection or views from either URI College of Pharmacy or UMass Memorial Health. So just the material and information provided will be for educational purposes. But to sort of talk about specifically sort of my experience, I have about 20 years of experience working in peds. And that has been from residency in Colorado through Hasbro Children's in Rhode Island and now here at UMass Memorial Health. And ultimately, we consistently see every year multiple hospitalizations for RSV. Most of the time, our severe patients are a child who might be premature or have congenital heart disease or previous chronic lung disease. And there's specific information that we look at for those, and that's sort of where we're thinking about giving currently monoclonal antibodies. But we even see typically children who are less than 6 months, peak being 2 to 3 months, being admitted particularly just for this respiratory illness.
Have you noticed any uptick in RSV cases either post COVID? Do you think there may be any?
Oh my gosh. Yeah. Oh my gosh. Yeah. Just from a standpoint of hospitalization, looking back, I did a little bit of looking just to prepare, and we really were sort of seeing like 2018, 2019, this was typically about 1.7%. And then there was a little tick up, and we saw 2019, 2020, 2.7%, and then back to our sort of peak that was a little bit off in 2021, and I can talk more about that. It went sort of back to sort of our normal 1 to 2% hospitalization rate. This year in particular, 2022, which was sort of our peak, and we talk about sort of the different timings, that this jumped to about over 5%. So that kind of gives you an understanding of this particular news cycle when we were really talking about where all those babies going in the hospital and why is their late sort of fall is truly like our typical numbers where we see lots of children getting admitted already. This was sort of seeing children in the emergency room, in the PICU, in the floor, and just all being RSV. lots and lots and lots of children being admitted. So almost a doubling of hospitalization rates.
I was going to say that's, partly why we are talking about this. And when we get to the vaccine, it's actually been in development for many years before this, the spike in hospitalizations, which is the most concerning, maybe not the most concerning outcome, but a concerning outcome. Were these children admitted with other viruses on board or other infections, or were they characterized by some of those chronic or medical conditions you mentioned earlier?
Yeah, that's a really good question, Jess. In the sense of this pick up that we saw, this was different than what we've typically seen. Usually, as I sort of mentioned, it was less, it's always usually less than 6 months. Not to say that we don't get children admitted for 6 to 12 months. And that's typically the norm. Most children will have RSV by the time that they're 1 year of age. But what we saw this time around were older children getting admitted. We still had younger babies, but we were still seeing then maybe children who were like 1, 2, 3, sort of that toddler age. Not always, but we did have more of a RSV with superimposed infection, so that we would see a lot of times, not a lot of times, but more than we ever had with not just viral sort of pneumonia symptoms, but truly bacterial pneumonia as well. And then really the idea is that sometimes in typical seasons of RSV, we'll have children who may have other respiratory viruses. That's sort of few, but can happen. And we didn't really see that either. We did see kind of the traditional, like maybe it was, more like another additional cold virus that they may have, rhinovirus or something of that nature. But this time, I think it was shifted more towards older kids. And that we even had a couple people who were admitted who were like adolescents, which was extremely abnormal. We would have never seen any other time.
And how did these people do? Like, did they have extended stays? I mean, like, what was your experience with this different makeup of patients compared to, the babies that would typically get it?
Yeah, I think it's all kind of dependent, right? Like our previous really sick children are sort of the ones that I described, someone who's, quite premature, congenital heart disease, things like that. Those are the typical severe patients that we would see admitted to the PICU. Most of the children, I would say, it was different in the sense that they had, the age, but then they may have that bacterial pneumonia, so that they weren't really severe bacterial pneumonia, but it was just unique that they were sort of seeing the superimposed bacterial infection. So they would be admitted, again, different in the sense that typically we would not admit them. They may have RSV, but they would typically at that age group be seen as an outpatient most of the time. But babies are really the young, less than 6 months are the ones that typically get admitted. And not all of them end up in the PICU because they're a lot of times just healthy babies who are within maybe their first month with a maybe weakened immune system that needs a little more supportive care within sort of our general pediatric unit. With that being said, most of those children that I was saying that had the additional bacterial pneumonia did stay a little bit longer just to be sort of treated for that bacterial pneumonia, but could be easily discharged for most of them, oral antibiotics, and being sent home.
All right, thanks.
So personally, a lot of the pharmacists I work with, they're younger kids. These are toddler age, going to daycare, things like that. I noticed a lot of their children, they were out because they acquired RSV in daycare centers, things like that. Do you think there's any correlation with post-pandemic, everyone, going back to being in person at these daycare centers, in schools, younger age children? Do you think that has any contribution to why we're seeing slightly older populations of pediatric patients acquiring RSV, or any speculation?
Yeah. I think that the idea is that once you have RSV, your subsequent infections are no different than most things, respiratory-wise. If you've seen it, then the next time around, it's not going to be as severe, and it's going to be maybe just for us, we've seen it multiple times, right? So ultimately, it's just another cold to us. So the fact that they hadn't seen it is sort of the working theory that was why we had a larger cohort now of children in that toddler age, particularly, that were RSV naive. And so that they were sort of getting, whether they were getting admitted or just the increase in numbers in general, because they were more susceptible, that they didn't get it during that period of time when we were masking and social distancing.
So what's interesting is that maybe this is truly just a bump, right, from this completely unique shutdown system, right, that happened post-pandemic or during the early stages of the pandemic, is that, do you anticipate, can anyone anticipate sort of what the pattern is? Because as we get into sort of the vaccines to prevent this ongoing dangerous illness for certain infants, I'm sure there's speculation to say, wow, we had this big bump. Do we need to study vaccines for older kids or ongoing immunity? Or do you think that this is truly just a factor of where we're at in the pandemic?
Yeah, it's really hard to say. I think like in the sense of just kind of for the listeners, is a typical RSV season is very similar to influenza season. Our peaks have always consistently for years been around that late December, January, February. And that, yes, do we see cases from time to time in October? We do. We're sort of seeing that sort of like the first cases coming then, and then sort of rising into November with that sort of peak, as I mentioned, and then sort of trailing off sort of into the spring. And what we really did see is that we had that usual pattern all the way through January, February of 2020, but then there were virtually no cases in 2021 during our typical January, February. Where we saw the increase in 2021 was in the fall. And that, I think, really took a lot of people by surprise. Why? But remember, this is when now most our people are coming back to school. And we started to see early cases in September and then peaking late September, early October. So by the end, like January 2022, we were sort of not really seeing many things after that. Like it was very shifted. And not like really elevated in our number, like still, like I said, 1.3, which is around typically where we are from hospitalization. But what we then saw this year was again sort of that idea of increasing cases late September, and really sort of our peak ended up in early November. We're still maybe seeing a handful of cases and it's sort of trailing off. But this is sort of what everybody's sort of scratching their heads a lot of, like, is this going to continue? Are we going to kind of shift back to where we were pre-pandemic? Or is this sort of here to stay, and that ultimately our season, because within like a tropical climate such as Florida, they may see cases a little earlier. So are we sort of in this different pattern, and that we may switch back with most of what we used to see in January and February, or are we going to see it be different?
That's certainly something I wanted to ask you, especially here in New England with your experience. We've had these bulking cases, these shift in cycles. Do you think we're tapering off now finally here in early March?
Yes,
Okay.
and looking at Rhode Island Department of Health data, there are still a few cases, but we have definitely tapered off, and that peak really was early November. And we are seeing, within the hospitalization, we haven't seen cases admitted in a handful of weeks.
Maybe that's a good point. We had in the list of questions you've talked about, great wealth of information about the epidemiology and where cases occur and what's happening right now. How is RSV spread? Like, how is it contagious? Because I think that's the other thing too, is, do masks help? And Jake mentioned daycares. Can you just give us a little primer on RSV transmission?
Sure. It is definitely your typical respiratory virus. It is droplets. It is able to live on hard surfaces for multiple hours. So you're sort of transmitting it by, touching droplets that maybe have been there. So it's very similar to all things that you think about with like cold-like viruses or cold-like symptoms. And that's typically, when we're thinking about it from a, prevention, you're always sort of just really thinking about hand hygiene, avoiding others that may be sick. And then, after touching their face or other things, to wash their hands, things of that nature. So it's really the idea of it being an upper respiratory tract infection and being contagious, like most cold-like symptoms.
And now that we understand a bit more about the problems and the gaps with RSV, how it spread, kind of the prevalence we're seeing, let's shift into our topic of conversation today. I want to introduce the new emerging vaccines that are coming up. It seems there's two that's seen recent success in some reports for these results and introductions for the vaccines to hit the market as recent as late 2022. So again, this is really kind of recent information. We're really interested to hear your perspective on the development of these emerging vaccines, how this could kind of change the game. But first, let's talk about current treatments and what you're using in your institutions to treat these patients.
Sure. Thanks, Jake, for the question. I think what's so exciting about these emerging vaccines is that when we are treating these patients, it is typically, for most patients, just supportive care. It is sometimes a trial of, if a child presents with, bronchiolitis, it may be a trial of albuterol to see if that works. But that's something, again, that maybe it's truly not a routine recommendation from AAP. There's, sometimes the secretions are very overwhelming, so the child has a difficulty feeding and those kind of things. And they can be sectioned. Again, not a routine recommendation from AAP. So there's really not a lot. You're really supporting them with fluids if they're dehydrated, supplemental oxygen, things of that nature. And so there has been one product that I've used maybe in 20 years. I would say count on one hand. It's an antiviral and can be an IV product or it can be administered through aerosolization, but that is a very cumbersome process. And so unless someone is severely ill, we are just truly not using that antiviral because the risks outweigh the benefits and truly just going with supportive care.
So we know once you're infected again with most viral illnesses, it's just the supportive care as you've described. Is there anything preventative we can do at the moment aside from these new immunizations?
Yes, I think for years there's been a monoclonal antibody called polatuzumab or Synagis, but the criteria and the indication for that medication or that monoclonal antibody is truly very specific. So it's really sort of getting at what I was talking about with those children or those infants that would be quite severe in their presentation. So a lot of times you have to be less than 29 weeks gestation. So our typical term child is 37 to can be 41 weeks of age, to give you kind of an idea of what I'm talking about of how premature that could be. So that they would be given polatuzumab starting typically in the beginning of November, and then ultimately going through once a month, giving this IV, the IM shot, and that happens once every month for 5 months. And that typically, if you are that premature, it is given at the start of RSV. So anytime in that period of time when you're a year old, if you fall within there, then that's when you're going to get it. There are other sort of differentiations, and it gets kind of cumbersome and it changes from year to year, but with its indication. But lots of times it's sort of like someone who might be less than 12 months of age with chronic lung disease. Theirs are a little bit more specific in the sense that their gestational age has to be, more like 32 weeks, and they have to be on supplemental oxygen at a specific rate. And then ultimately, even if you're in the year to 2 years of age and you have ongoing chronic lung disease, you may be able to receive polatuzumab. And then again, as I was mentioning, the children who are having congenital heart disease, those children are also at severe risk. So a lot of times we are giving them RSV prophylaxis with polatuzumab within that first year as well. So there's some others in there, and not to belabor the whole point, but it's really about being premature congenital heart disease, chronic lung disease, where we really are we know that those patients do worse, and that's why that medication is given.
It sounds like that's why we're talking to the pediatric specialists here, is because I think probably not a lot of people know how these severe treatments, how they're treated in the hospital and how they're prevented. So it's interesting that builds into the sort of, okay, so now we have vaccines, who they're going to be used and how they're going to be used. So Pfizer developed what they're calling a bivalent RSV prefusion F vaccine. They've been in research and development since early 2018. It's really building on decades of research. So they gave this vaccine to pregnant women in their third trimester in this trial called the Matson trial. And this is one of two vaccines. We'll talk about the other one in a little bit. So their outcome was neutralizing antibodies prevalent in infants through the first 6 months after birth. So you're talking about treatments that are given every month. Here we're talking about a vaccine that results in antibody persistence when they're more vulnerable for infection, as you've described. Now, what's interesting is that, and I want to hear your take on this, that Black pregnant mothers were only 1/5 of the study population, but they suffer rates of maternal mortality related to pregnancy at complications 3 times higher than white pregnant mothers. I don't know if that translates into Black infant rates of RSV more. What are your thoughts on sort of the incidence of RSV by Black versus white infants?
From the standpoint of race and ethnicity, I don't think that we really see differences in rates of RSV. The only thing that may sort of from a socioeconomic perspective take hold is sort of like we do know risk factors of crowding, having two or more siblings within a room. There are other risk factors such as lack of breastfeeding, as well as exposure to the tobacco smoke. Daycare, of course, is a risk. Thinking about it from a standpoint of socioeconomic, outside of sort of race and ethnicity, does probably play a role of who we might see as becoming infected. I think from a standpoint as a Matisse child, there's definitely the idea, just as we sort of know with COVID and flu, that these upper respiratory tract infections can be detrimental to pregnant mothers. And so like that can play a role with like low birth weight, prematurity, things of that nature. And so we do know from a prenatal care perspective, sometimes that does play out just in the sense of like having them like thinking about it from vaccinations and flu and things of that nature.
Yeah, in terms of uptake and traditionally, I think the bringing Black mothers into this, not only is it maternal mortality, and it's a very complex beyond the scope of this podcast, but yeah, in terms of uptake of those other preventative, highly successful and safe vaccines you mentioned, COVID and influenza, the uptake has gone down, or there's differential uptake based on race. But in terms of how this, and that will affect in terms of who do we give this vaccine to, right? If it's it is successful, it's safe. Do you want to comment on that, on what you think the uptake of RSV may be?
I think like from a standpoint is, as we know what you're saying about COVID and flu, I think it's definitely someone in prenatal care is always offered those vaccines, because we know that, particularly, I'll use the flu example, like if we're giving pregnant women sort of influenza shots, we know that the rate of when they're most vulnerable as infants, being that less than 6 months and not being able to have the vaccination, that they're going to be covered. Right. And that's helpful. It's helpful for the mother and then subsequently to the infant, given that we know that these upper respiratory tract infections can sort of see lower birth weights, as I mentioned, prematurity, that can take effect. So that's protective of sort of the fetus. And then ultimately, like later, if everybody around that infant is vaccinated, then that also sort of is helpful in a prevention of that first 6 months. So I think like from a standpoint, this would be something very similar, but as you were sort of mentioning, those rates are lower. We're sort of having this vaccine sort of overload in a sense from COVID. And so, it will sort of depend. I think the biggest things will be education around how it can be preventative through that 6 month period of time. And then based upon sort of this trial, and what I would like to see sort of in the future from subsequent information is really how long is that immunity going to last? We said, like I was saying, like from a standpoint of influenza, right? We need that 6 month shot for infants themselves. Where would this RSV, like if we had another vaccine, where would that go? And how would that be implemented within the schedule?
Yeah, and the uptake is always, it's great. The Matisse trial showed that it's effective, and that even at 6 months, 50% of more than 50% of infants had neutralizing antibodies, and less severe, less hospitalizations and less medically attended visits. But it's always, when we talk about vaccines, it's sort of, okay, so you talked about the success of influenza vaccine. Okay, we can work on that, and then we give Tdap vaccine to protect infants until they get their DTaP first shot at 2 months, and that's also given optimally in the third trimester. Now there's COVID vaccine that's also very effective to protect infants and the mothers from the detriments of getting infected with COVID-19. And so now here's vaccine number 4 for pregnant women.
Right.
Is this too many, right? And then it becomes sort of, the 3 vaccines I just mentioned are universal recommendations. It's interesting to see what ACIP will choose in terms of, is it people who have higher risk factors or not, and can we actually get people who are at the highest risk to get it or not, or do we have a universal vaccination recommendation? I don't know what your thoughts are on that.
Right. I think like from a standpoint, like it would be hard. It's almost in the sense that you are going to need it to be, in my thoughts, universal just as well. We talked about this fluctuating right now sort of season. so what do we call the season? And then sort of some of these specific severe risk factors, we're talking about, well, during the RSV season, we're going to give these shots during that period of time at any point within that year. But for the most part, we may not know that these children are going to be premature. We may not know that they're going to have chronic lung disease. We may not know that they're going to have congenital heart disease. So it's going to be hard to sort of, and we do still see, as I mentioned, healthy infants that do get RSV that get admitted. It's, they do much better. They may only be here a short period of time comparatively to some of those others that I've mentioned, just sort of have maybe a more severe disease, maybe a ICU admittance. So it's probably going to have to be, because it's sort of a moving target in a sense, to sort of see where this vaccine should be probably very similar, I would think, to Tdap, where you're giving it 27 to 36 weeks, gestation prior to, in that third trimester, prior to giving birth, so that they are protected. I think in this trial, I think it was maybe even the subsequent phase 2 trial, they definitely said that within the immunization, those neutralizing antibodies were there at like 7 weeks. So that kind of gives you an idea of like where that vaccine might need to be. But ultimately, can you be very specific to which mothers should get it? And I think that would be a hard call.
Lots of questions, not a lot of answers, but it's good that we have this. Jake, maybe we should let the kind offering of Dr. Matson's immense time to our podcast go, and we can talk about older adults. Other than maybe we ask the ultimate question, Jake, take it away.
So Kelly, what is the regimen for RSV vaccines for pediatrics and pregnant mothers?
I think it's definitely something to be excited about. It's definitely on the horizon. I'm looking forward to sort of what ACIP sort of recommends, but I'm looking forward to where this comes within pregnant mothers. Is there going to be something that may be on the horizon even later for children 6 months or older? So I think that this is a great way, as Dr. Bradford mentioned, this research has been going on for decades. And so for it to come to this close to fruition, I think is very exciting for all of us in pediatrics.
Absolutely. Yeah, it's extremely promising to prevent pediatric illnesses. So we're very excited to see where this carries us. I would like to thank our featured guest and expert in this field, Dr. Kelly Matson, for joining us for this pediatric portion of the episode on the regimen for emerging vaccines. You've given us great insight on not only RSV and the current battle we're seeing across the state and nationally, but how medicine is adapting this decade to help prevent transmission in pediatric illness. So thanks again for coming on. We'll let you go. Hopefully you get home safely and make it through the storm.
Thank you, guys. Thanks so much for having me.
So Jake, that was a great conversation with Kelly. Let's sum up a little what we've learned and maybe transition to the older adult side of RSV severity and effects.
Yeah, absolutely. So now we know children are affected over 10 times more than over adults. RSV is the leading cause of hospitalization among newborns and younger children, with the CDC reporting 60 to 80,000 hospitalizations per year among those under 5. And as Kelly explained, we're seeing it in not just infants and newborns or preterm babies, but also 2, 3, 4-year-olds, 5-year-olds. Pediatrics are a high concern in the medical community. They're ultra vulnerable to a multitude of risks as they're seeing, this brand new world and all the illnesses and dangers that present to them. But RSV also strikes at the other end of life. It causes more than 180,000 hospitalizations and over 14,000 deaths among older adults every year.
I should tell you too, my family actually had RSV. They,
Really?
my relatives who are older than 65, 2 of them have asthma and other medical conditions. They're over than 65, and all of their symptoms, they had to go to a visit, that's a cost. And they said, everything looks like RSV here. So, and I was super surprised and sort of prompted this podcast to say, wow, I always thought this was a pediatric. Again, my goddaughter actually had RSV, over 20 years ago, frequently, and had to go to the emergency department to get that care. So I'm sort of seeing this in both sides of my life here. So excited that there's vaccines, which is also a huge part of my life here. And so, again, they often see that severe infections. CDC says 400,000 cases globally, the 60 to 120,000 older adults hospitalized. And again, those, fatalities, which notably Kelly didn't mention. So do you want to talk about what other risk factors people older than 65 have who get RSV?
Well, yeah, well, that's the biggest concern. She did discuss with the pediatric patients, we see the progression to pneumonia or, other sort of respiratory or viral illnesses that can go along with RSV. But with patients 65 and older, if they have any type of heart or lung complications like COPD, or they come in also with pneumonia, any type of heart failure, cardiovascular disease, these types of comorbidities that are the highest among the elderly population, that is when they have a severe higher risk of a more severe case of RSV, and then again, mortality, death, this older population. That's why it's arguably more important for older adults to prevent infection and successfully immunize them. Again, these people have a much larger window of when this infection can take hold and when they're at a higher risk of more severe complication. So while we see pediatric populations affected more, and that is a high concern, have to address, which population may be more important to receive these vaccines, where should we focus our efforts. The older populations, 65 plus, are a strong concern for, again, more severe.
And we should be very, very clear, though, too, is that RSV, again, doesn't lead to infant deaths, but it leads to significant morbidity. With adults, we have this mortality. Realize that influenza, which we have many, many successful and improved vaccines over time. Only 2/3 of adults in the nation and in Rhode Island actually get the influenza vaccine. So even among states where we have high uptake, we still see nationally up to 80,000 deaths from influenza a year and multiple hundred thousands of preventable hospitalizations. So while RSV, it's important that we have this vaccine, and Jake, you'll tell us a little bit about the study. I think it's really important to think about, as we talk about vaccination, it's good that we have more vaccines. We can give multiple vaccines at once safely, but we really need to focus our efforts on implementation. But let's talk a little bit about this well-done trial in older adults.
Yes. So most recently with Pfizer, again, there's two of them. We'll discuss a little bit on GSK and then Pfizer's. Pfizer was the one who did the Matisse trial for pediatrics. So Pfizer completed recently the Renoir trial, RSV vaccine efficacy study in older adults. Again, this is a bivalent RSV prefusion vaccine tested in those 60 and older. To date, again, these studies have been going on for quite some time. Over 37,000 patients were tested in this study, reporting around 66 to 70% efficacy in mild to moderate cases, with a much higher 85% efficacy observed in severe cases of elderly patients. And then a little bit of discussion on GSK, even higher, 95% efficacy against severe cases. So we're seeing some great success with these new emerging vaccines, and both of these companies are pushing for approval for both of these so we can start the rollout and immunize these high-risk populations.
Yeah, I think the things that Kelly brought up are still applicable here. Like you said, there's a wider range of exposure. All these adults, basically everybody gets exposed to RSV, which provides some immunity. We know the biggest risk to immunity, whether it's COVID or flu or other things, is that you have waning immunity. Your cells, you have fewer of them, or the ones you have don't work as well. That's just an aging thing. So it's, this becomes the sort of thing we've been talking about COVID vaccines, is you have an annual booster like we do with influenza. This was only a 6-month trial where we looked at, immunity out to 6 months. Older adults in the GSK trial showed efficacy up to 7 months. So is this going to be an annual vaccine? Is this going to be given with flu? We know there's no combination vaccines, which are always helpful to encourage uptake. So, still a lot of questions on the older adults. And
love to see some follow-up on these studies just so we can, make a better assessment. But I guess let's talk the regimen for these emerging vaccines.
Let's keep getting vaccines out there. We know, we saved millions and millions of lives, and people who were vaccinated against COVID-19, always going to promote that people need that bivalent booster. People are much less likely to have these severe outcomes, both in older adults, especially death and hospitalization. Everybody's really indicated for them. We have these two groups at high risk for RSV. Already there's other vaccines we've talked about that they're getting vaccinated against. I think if we can get a strategy, follow the national immunization strategy, which is that every time someone encounters the medical system, offer vaccines and have those people being able to give it to them, not just pharmacists who are doing the majority of vaccination. We need to expand this to, OBs and family medicine. We need those vaccines sort of everywhere. And when people are willing to get it, people are trained to give that to them, and that we keep sustaining the public perception that vaccine saved lives. And I think RSV vaccine will do the same.
Prevention is the best treatment.
All right.
I'd like again to thank our featured guest, Dr. Kelly Matson, for being on earlier today, having such a great open discussion on these new and emerging vaccines, especially those affecting pregnant people and higher risk pediatric populations. And then again, the elderly populations, as we've discussed. Be sure to follow us at PharmDPubHealth on Twitter, Instagram, subscribe, same at PharmDPubHealth on YouTube. Stay tuned for next week's episode on smoking cessation. We've got some wonderful guests from the American Lung Association and Rhode Island Department of Health. Smash that subscribe button so you don't miss it, and listen to us everywhere we stream: Spotify, Apple Podcasts, Amazon Music, Google. We'll catch you next time.
All right. Thanks, Jake.